Welcome to the HFSA Heart Failure Patient and Caregiver webinar series. Today we're going to have a presentation on understanding and managing ATTR amyloidosis. My name is Sharon Huerta, and I'm a clinical nurse specialist and the heart failure quality manager at Baptist Memorial Hospital in Memphis, Tennessee. I have been on the HFSA patient committee for the past 2 years. Thank you to our 2025 Patient and Caregiver Webinar Series sponsors, Merck, Abbott, AstraZeneca, Novartis, Novo Nordisk, and to our ATTR webinar sponsor, Pfizer. Today, you'll be treated to presentations by heart failure providers Dr. Andres Carmona Rubio and Dr. Tolu Agumbayade, as well as from heart failure patient advocate Sean Riley. They will provide valuable insights into ATTR amyloidosis, and today we will learn to recognize key symptoms, understand the importance of early diagnosis, and explore current treatment options. The information provided is for educational purposes only and not medical advice. Always consult your healthcare provider before making any treatment changes. We will take questions and answers from the question section to present to the speakers at the end of all the segments. Please put your questions in the questions section of the chat. At the conclusion of the webinar, participants will receive a survey link. We encourage you to complete the survey as it helps HFSA improve programming for patients. First, we will hear from Dr. Carmona Rubio. He is a staff cardiologist in the section of heart failure and cardiac transplantation and amyloidosis center at the Cleveland Clinic. He received his medical degree from the Universidad del Zulia, completed his internal medicine residency at the University of Buffalo, general cardiology fellowship at Cleveland Clinic, Florida, and lastly, advanced heart failure fellowship at Cleveland Clinic main campus. He is actively involved in multiple heart failure clinical trials. Additionally, Dr. Carmona Rubio serves as a member of the HFSA patient committee.
Thank you so much. So to begin with, we just basically want to try to explain so you have a better understanding of ATTR amyloidosis, and we'll try to talk about signs, symptoms, and how do we think about when we're making this diagnosis, what are the tools that we need. These are my disclosures. The objectives, like I mentioned, we're going to try to understand ATTR, what it is. We're going to try to see what the types are, variants or hereditary versus wild type, and we'll talk about the differences, causes, risk factors, and some genetic considerations that we should have. Then we'll talk about the common symptoms and the progression, diagnostic tools and biomarkers that we use, and the very important part of kind of spreading the word so there's early detection. So when we talk about ATTR amyloidosis, it's, in technical words, is a broad spectrum of diseases that result from misfolding of proteins that aggregate into beta sheet amyloid fibrils. There's over 35 of those precursor proteins that have been identified that give rise to the disease, characterized by extracellular deposition of these insoluble amyloid fibrils throughout various tissues. So, to simplify this, is just these proteins that start basically acting up, and then they form and accumulate into these amyloid fibrils. There's 35 of them, and then they accumulate in different organs, and depending on the organ that it affects, it causes disease in that organ. And so that protein initially is folded, and so when it starts, basically I call it acting up, then we see that it starts misfolding, and when it misfolds is when it starts clumping together and forms the amyloid fibrils. So we see here how it starts clumping together. We see it in different methods. This is electron microscopy when it looks a little apple birefringent. That's kind of a test questions for doctors. It's pathognomonic. It's how we see it on electron microscopy. The way that we kind of understand the nomenclature or the types, we kind of divide it by each letter. And so the A always stands for amyloid, and then it's followed by the misfolded protein. So for example, in light chain amyloidosis, it's AL. In TTR, which is what we're talking today, it's amyloidosis, and then it's followed by transthyretin, and then followed by, if it's wild type, if it's variant, same with other types of amyloidosis like AA, A1, A4. And then I usually call it like the last name, where it's affecting. So CM on the right side, it means cardiomyopathy. If it was in the nerves, it would be polyneuropathy. So the pathophysiology, we see that this is a problem that comes from a protein that's produced from the liver. That's called transthyretin. And so, transthyretin, it's a transporter of thyroxine, which is the thyroid hormone, and retinol, which is vitamin A. And so we have that this tetramer, which basically means four particles that are the same, start misfolding. And so when it misfolds, it starts breaking apart, basically. So the TTR that you see there after the liver, that image, starts breaking apart. It forms dimers, which means two particles together, and then ultimately monomers. And those monomers start misfolding, and then they clump together and form these amyloid fibrils. This is just basically another graphical way, and just basically I want to point out that when we look at this picture, it's just so you understand that in the end, it doesn't matter where the protein is coming from, but it misfolds, and then when it misfolds, even if it's from the bone marrow or the liver in terms of TTR, it accumulates in the tissues and then it causes disease. And here's an example of what happens if we don't catch it early and we catch it in the end stage. This is a heart of somebody that had a heart transplant. And so this is a TTR heart. So it's very, very thick. As you can see in the bottom part, that's the ventricles. You see that there's a lot of thickness, and the chambers on the top are really enlarged as well. When we come and talk about the differences between the two subtypes of TTR, which are wild type and then the other one that's variant, we see that wild type, it's not a mutation that is in the TTR gene. And because of that, it's not hereditary. It's not passed along from your parents. And you're not passing it along to brothers, sisters, or children. So that's really important. The variant, it is hereditary and autosomal dominant. The wild type, it's usually presented in patients that are more than 65 years, especially in the 70, 80 range. And variant, we can see it varies a lot depending on the type of mutation or variant that you have. It can be from 30s to 70s. In wild type, it's more predominant in male and females. And in variant, it depends on the variant as well, but it can be in both sexes. In wild type, it's only in white males, and in variant, we see that it depends on the variant, but in the United States, we have that African ancestry with V122I. We see that it's more common in African Americans or Afro-Caribbeans, as that we have in some of the southern states. Something of note is that for the wild type, there's about 25% of patients that are more than 80 years old that when they unfortunately pass away, then when they do the autopsy, there's some studies that show that that TTR wild type was in those patients. When we talk about the epidemiology, it varies across the world. In the United States, as you see in blue, is the V122I is the most common, although we do have the T60A, which is what we call an Irish variant, because that's where that variant comes from. Those are the most common, but definitely the V122I is the most prevalent. And then in the rest of the world, the other one that's the most prevalent is V30M, mainly in like Spain, Portugal, and Brazil. There's mixed phenotypes are very common. Some patients present only with cardiac and heart issues. Some present with only nerve issues. But very commonly, we see actually a mixed phenotype in these variant patients where they have heart involvement and they also have nerve involvement. The V122I is present in about 3.5% of African Americans, so that's really important to know. And then that T60A is the Irish descent variant that I was mentioning. Something to mention is that also that V122I, sometimes you would see it as V142I because there were 20 amino acids that were added, just in case different doctors call it different ways, but it's the same thing. So red flags that docs need to be aware and patients need to be aware so they understand how to make the diagnosis or understand if they're having symptoms because of amyloidosis. And so, I'm a heart failure cardiologist, so I see very often patients with heart failure. So if the patient is having shortness of breath, swelling in the legs, they're feeling bloated, they're getting full really quickly, their weight is going up really quickly as well without any reason or any explanation. If they have like palpitations, heart racing because of things like atrial fibrillation and rhythm issues from the top chamber. Or they have maybe slow rhythms, and because of that, they feel like lightheaded, dizzy, very tired. They can also have valve issues from the heart standpoint, like aortic stenosis that we see somewhat often in patients with amyloidosis. Other things that are not heart related, but that we see very often related to ATTR are musculoskeletal things like carpal tunnel syndrome, spinal stenosis, bicep tendon rupture. We see trigger fingers, rotator cuff issues. At times, patients can have other orthopedic problems like hip replacements or knee replacements, but that not necessarily related to amyloid, but we do see it very often. Other issues are neuropathy, like it can be pain, numbness in the fingers or in the feet, muscle weakness. We also can see some autonomic dysfunction like orthostatic hypotension, like basically when you change position, your blood pressure drops too much, and so you become very symptomatic. Other things like chronic diarrhea, weight loss, erectile dysfunction is also something that we see. And other manifestations like enlarged tongue called macroglossia, or purpleness around the eye, and some kidney disease. But those are more common, the things in red in patients with AL, although can be present in patients with ATTR as well. We see it usually in patients above 50 years old, but like I said before, it depends on the variant. Important to also look at his family history, some ethnic risks, like I mentioned, if somebody comes from a certain area, or for example, if they're African American, we do see the V122I more prevalent, and so those things should be red flags to screen for amyloidosis. And this is just a graphical way to kind of explain the same thing I was touching upon before. And so how do we make that diagnosis? So first we have to suspect it. We see those symptoms that I was mentioning. On physical exam, you might have an abnormal rhythm, abnormal lung sounds. They might see some swelling, some abnormalities on EKG, some abnormalities that we could have seen on echo if you've had one already, or on MRI if you've had one already, on a Holter or event monitor that they've put on because of rhythm issues or symptoms that you've expressed. And so the basic diagnostic workup that we recommend is, well, the history, the EKG, and the echo is very important. And then we also recommend some biomarkers, some lab tests that are very helpful for patients with amyloidosis, the BNP or the NT-proBNP, the troponin T or the high sensitivity troponin. And in some cases, in some institutions, they measure actually TTR levels, which is the prealbumin. We can also add to that echo with special techniques like strain, and we also can look at cardiac MRI. It's very, very important when you're looking for amyloidosis that the first thing you need to do is your doctor needs to rule out that you do not have AL, because AL is something that is much more rapidly progressive and needs to be treated immediately, and you need to see a hematologist. And so if that indeed is the case, then you go down the hematology route, you get a biopsy, you get diagnosis, and then you get put on treatment, then follow with the hematologist and the cardiologist. If that is negative, which is the path for ATTR, then usually you get recommended a bone scintigraphy, or we call an amyloid nuclear scan. And so if that's negative and there's still some suspicion, you might still be recommended to get other tests like a cardiac MRI or go towards a biopsy to confirm. But usually when it's negative, amyloid TTR is unlikely. When it's positive, that is a non-invasive way of us making the diagnosis. And then so we can call that is ATTR-CM. And then we do genetic testing and counseling to be able to understand if it's variant or if it's wild type. Something that's very, very important is identifying this at the earliest stage as possible so we can make a big impact and change the disease course. And so things that we've been trying to do with education and forums like this one, talking to patients or others, talking to other doctors, scientific conferences, publications to try to make everybody aware of what the new advances are, or explaining the disease, community engagement, which we've done, for example, here in Cleveland. Like we have a patient that is a famous NFL player that's going to do something at the Hall of Fame. And so that's just trying to get engagement so patients in the community are aware of this disease, and we can screen them as well. So it's kind of empowering them. Also, AI has been very helpful with electronic health records, with like machine learning that try to help us try to identify these patients when maybe the doctor has not suspected it by looking at different clues. Tissue screening, we've been doing at different institutions here at Cleveland Clinic. We do spinal stenosis and carpal tunnel syndrome. And so those patients usually get a biopsy if they meet criteria to try to see if they actually have amyloid involvement. And then also is a biobanks with those patients that maybe a family member was positive and then they got tested and then they have the variant. So to get those patients seen by doctors that are familiar with the disease to see what exactly they need to do. And then other diagnostic tools that they've been slowly advancing to improve in the detection of amyloidosis even early on. And hopefully in the future, some maybe biomarkers that actually kind of let us know if somebody's at risk for the condition. So kind of the last slide. So those opportunities to identify early, the important thing is that because we want to try to diagnose this as early as possible. So more on the left side of the screen. We want to avoid having to diagnose this on the right side of the screen where patients already have thickening of the heart. They've had heart failure symptoms that are significant. They have EKG abnormalities. Their biomarkers are very abnormal. And it's not a lot that we're going to be able to do with even the therapies that we have available. Ideally, we diagnose this as on the left as possible so we can make an impact and start these therapies that are pretty important and have made a significant impact in the amyloid community. And so kind of talking about the therapies, I'll stop there and let Dr. Agombiade talk about that a little bit more, and we'll talk at the end of the Q&A.
Thank you, Dr. Carmona Rubio. If you have any questions for him, please post them in the question section for the Q&A segment at the end. And next we will hear from Dr. Tolu Agombiade. She is an advanced heart failure cardiologist and the medical director of the Advanced Heart Failure LVAD program at Virtua Health. She earned her medical degree from Harvard Medical School. She completed her residency in internal medicine, fellowships in cardiovascular disease and advanced heart failure and transplant at Johns Hopkins University Hospital. And she is passionate about caring for patients with heart failure and improving patient awareness and education about their health conditions.
Good evening, everyone. Thank you, Sharon, and it's a pleasure to be on here with you guys this evening. So I will be talking about the treatment of ATTR cardiac amyloidosis. So, when we think about the treatment, there are a couple of goals that we have, right? The goals are to improve heart failure symptoms for our patients, to slow or halt disease progression, to prevent hospitalizations, and also to maximize longevity. I'll touch briefly on some of, so when we think about treatment, we're going to spend the bulk of the talk discussing disease-modifying therapies, but some other things that are commonly used to care for this patient population is our treatments that can actually help improve symptoms. And so when we talk about that, we're talking about diuretics, for example, and that includes the loop diuretics, so Lasix or furosemide, bumetanide or Bumax. We think about torsemide or Demodex, and all of these really help with congestion that can lead to very quick and short-term improvement in symptoms. And as adjuncts to the loop diuretics, we utilize mineralocorticoid receptor antagonists such as spironolactone or aldactone or eplerenone. And then more recently, the SGLT2 inhibitors are really being used for the full breadth of heart failure care. Additionally, one of the other things, and Dr. Carmona mentioned this, that patients can have is the autonomic dysfunction that related to the cardiac amyloidosis. And so to treat that, especially if someone's having hypotension or low blood pressure, sometimes we can utilize midodrine. There are all other kind of aspects to the care of this condition, but I'm going to now switch gears and focus on disease-modifying therapies. So when we look at talk about cardiac amyloidosis, we've already heard that transthyretin is made in the liver, and really it should be in the form of a tetramer. However, through either the aging process or genetic substitution that can sometimes occur, there is dissociation of this protein, and it ultimately misfolds and forms these fibrils that result in heart disease and peripheral neuropathy. There are therapies that have been developed to target different points in this pathway. The two that you're most likely very familiar with are the stabilizers, which act in the third box here. And what they do is that they stabilize the tetrameric form of the TTR and thus minimize the likelihood that it will dissociate. And then the other class is in the second box on the screen, which are the silencers. And they work a bit more upstream to decrease production of the TTR protein. There are also additional therapies in the investigational phase that work further upstream, and those are the gene editing therapies, and then also downstream to address the proteins that have already been deposited in the tissues in the body. We're first going to talk about tafamidis. So this is first-in-class drug. It was approved by the FDA in 2019 to treat ATTR-CM. It's a stabilizer. It works by binding to the healthy tetramer that we previously showed to prevent breakdown into the monomer and ultimately the fibrils. It's a pill that's taken daily. It's either one pill or, depending on what insurance will cover, some patients end up taking 4 pills. And the trial that looked at this was the ATTR ACT or ATTR trial. And so they enrolled 441 patients, and they followed them for 2.5 years. And patients either received the 20 milligram dose or the 80 milligram dose versus the others, and then versus placebo. What they saw in this study was that there was a decrease in mortality, so almost 30% versus 43%. They saw lower rates of cardiovascular hospitalization. The medication also led to a slower decline in quality of life, as assessed by the KCCQ, and also a slower decline in functional capacity when they looked at 6-minute walk distance. There was an extension study that went out to 5 years, and they also saw that improved survival was maintained out to that point. We will now talk about another medication in this class, which is acoramidis or Truby. This was approved by the FDA in November of 2024. The drug came about basically via an observation that there was a specific rare mutation, the T119M, in the gene that actually encodes for TTR. And in the patients that had this and had the V30M mutation and that were heterozygous for that, it was actually found to be protective. The company was then able to develop a compound that mimicked the ability of that mutation basically to bind to the TTR molecule and prevent its dissociation. For administration of this, it's 4 pills that are taken twice daily. And the trial that looked at this was the ATTRibute-CM trial. They enrolled more than 600 patients and followed them for 30 months. They were randomized to receive either acoramidis or placebo. And they also showed a reduction in cardiovascular mortality and recurrent cardiovascular hospitalization. So the initial study showed an improvement in the combined outcome. The curves did separate early, and this really highlights the importance of early treatment. The trial itself did not demonstrate a mortality benefit alone, but this is likely because they enrolled a less sick population than the ATTR ACT trial, because at that point there were really no other therapies. But as the studies continue to evolve, we're finding patients earlier, and so enrolling a less sick patient population. But when they did follow this out to 42 months, they observed a mortality benefit. We'll now switch gears and talk about another class of medications that are approved for treating ATTR-CM. And these are the silencers. We're going to talk about vutrisiran first. This was approved by the FDA earlier this year in March of 2025. This medication works via RNA interference. And so they get into the liver cells and bind to the messenger RNA that encodes for the transthyretin, and that prevents it from being translated into protein. So you have less of the protein being formed. It's administered every 3 months subcutaneously, and that just means that it's going into the just under the skin. And the study that looked at this is a HELIOS-B trial. And prior to this being approved for the cardiac indication, it's worth noting that this was being utilized to treat the hereditary polyneuropathy of amyloidosis. So in the HELIOS-B study, they enrolled about 600 patients. They followed them for 36 months. And it's worth noting that about 40% of patients in this study were actually on tafamidis also. They demonstrated an improvement in the primary endpoint of all-cause mortality and also recurrent cardiovascular events. They also saw less of a decline in functional capacity as assessed by the 6-minute walk test, and also less of a decline in quality of life when they looked at the KCCQ. So like the ATTRibute-CM trial, they observed a reduction in mortality when they also looked at the extension study, and they went out to 42 months. Another silencer that's currently used to treat the neuropathy associated with amyloidosis is eplontersen, and we're expecting to see results of the cardiac study soon. And so eplontersen, it's an antisense oligonucleotide that inhibits TTR production. So if we look in the second box where it talks about treatments of block protein synthesis, on the right side where you see the ASO, what happens is it binds specifically to the messenger RNA that basically codes for that transthyretin protein. And then it triggers a breakdown of the transthyretin, the RNA, the TTR RNA, leading to decreased production. This is administered every 4 weeks, and it can be self-administered in contrast to the vutrisiran, which needs to be administered by a healthcare professional. And in the study, they enrolled more than 1,400 patients, and we're hoping to hear results of that in 2026. We'll now discuss some investigational therapeutic options. So one of these is gene editing. In this case, the medication gets into the DNA and it snips out the part that makes the TTR protein. It then links the two ends of the DNA back together. And the goal of this therapy is to permanently silence hepatic production of transthyretin. It's a single infusion, and the preliminary data for this is actually very encouraging. In a phase 1 study that included 36 patients, they did see a reduction in serum TTR out to 12 months, and the phase 3 study is ongoing, and that's the magnitude study. So we're looking forward to seeing what that shows. So far, we've spoken a lot about therapies that can reduce production of the TTR protein. We've spoken about therapies that stabilize the protein once it's been formed, to minimize degradation into the monomers that then deposit in the tissue and cause problems. But what about for the protein that's already deposited in our tissue? And that's where depleters come in. They focus on amyloid protein removal. There are 3 of them that are currently under investigation, and these are monoclonal antibodies that bind to the TTR deposits in the tissues and then lead to their removal. On the right of this slide, you can see the images from 2 patients from the first trial. What they saw is that there was a reduction in myocardial uptake on the PYP scan. So you can see that baseline is the first picture, then at 4 months, and then at 12 months. You can see decreased uptake. And when they looked at the MRI data, they also saw a decrease in the cellular extracellular volume fraction. They saw a decrease in NT-proBNP, which is one of the biomarkers that we look at when patients have amyloidosis, and also decrease in troponin levels. So it's all really encouraging data thus far that's exciting. We hope to hear more about those studies soon. So how do we kind of look at therapy for ATTR-CM in 2025? I would say that, there are several disease-modifying therapies that we've heard about already this evening, 3 of which are currently approved for treatment. And they all improve survival and morbidity and quality of life. We consider them all to be strong first-line therapies. And the question always comes up, okay, so which one do we use first? I think that, choice can be driven by many variables, and you have to take patient preference. Do you prefer to take a pill, or do you prefer to get a subcutaneous injection? Some patients, how many pills do you prefer to take? But we also need to look at the fact that insurance, to some degree, is also going to dictate what our patients can receive, in addition to the cost of these medications when we look at the copays. And at the end of it, it's really shared decision-making between the physician and the patient that's in front of us. There are some unanswered questions when it comes to treatment, and I'll just put them on here and we can hopefully discuss some of them in the Q&A. But the questions that still exist, I like this from a paper that was published by Griffin et al. Earlier this year. It talks about what's the best initial therapeutic choice. You know, how do we do stabilizers? Which one? Is it a stabilizer versus a silencer? And then do we do multiple therapies? Are we combining therapy? Do we switch people if we're seeing signs of progression? And how do you define the progression? But I think at the end of the day, for now, it still boils down to shared decision-making. So I'll stop there, and I'll be happy to take questions at the end.
Thank you, Dr. Agunbayade. Next, we're going to hear from Sharon Riley, who is a patient advocate and a current member of the HFSA Patient Committee. Sharon resides in New Hampshire and is a retired nuclear reactor operations training instructor and a professor of nuclear engineering technology. He was diagnosed with the rare disease hereditary amyloidosis in March of 2019 and began treatment immediately. Now, 6 years into treatment, Sharon is pleased to report that progression of his disease appears to be halted. Sharon volunteers as a speaker for the Amyloidosis Speakers Bureau, a nonprofit organization whose mission is to help educate the medical community.
Well, hello, everybody. Thank you for that introduction. It's great to be here and talk with you. My name is Sharon Riley. I have hereditary amyloidosis. I've actually got the T60A variant that you heard of earlier, which tends to be specific to people of Irish lineage. My name's Sharon Riley, so you can kind of do the math on that one. I was diagnosed with the disease in, early March of 2019, but that was after about a 6 to 7 year journey to diagnosis. The first part of my story here all took place in New Hampshire. Like I said, 6 to 7 years prior to diagnosis. My first symptom, I guess, that came in, I started experiencing carpal tunnel type symptoms in both of my hands. So that was around 48 or 49 years of age at the time. So I ended up having bilateral carpal tunnel surgery. I didn't think much of it. The hand surgeon we just figured it was regular carpal tunnel that you normally see in people. Little did I know at the time, and little did that hand surgeon know, what actually was happening was I was starting to get the early symptoms of the disease. Not only that, but I ended up shortly thereafter having to have trigger finger surgery on 3 different fingers. So that was early symptoms of the disease. In parallel with that, I started experiencing numbness in my left foot and my left ankle. I had previously had vascular surgery on that leg, so I was kind of attributing that numbness to maybe some nerve damage due to the surgical process they did there down in my ankle. Again, little did I know what was actually happening was that peripheral neuropathy was starting to build in from the disease. It has since spread up both of my legs into my hips, and also up both of my arms from my hands up to about the level of my elbow. That peripheral neuropathy has caused pretty significant muscle weakness in both of my legs, to the point where I can still walk around. Stairs are very difficult, and I do often, especially if I walk great distances, need to use a cane. Fast forward from that time that I had the carpal tunnel surgery, about a year or 2 later, I was at home. I started feeling an uneasiness in my chest. It felt like I thought I was having a heart attack. I was taken to the hospital by ambulance. I was feeling dizzy, like I was going to pass out. They brought me into the emergency room. They didn't see any symptoms of a heart attack. What actually was happening, what we now know was happening, was I was actually feeling an acute attack of hypotension or low blood pressure, if you will. And that was just a fact that the neuropathy was also starting to affect my auto neurosystem. So I was getting autoneuropathic symptoms. I still battle with that to this day, and I take the drug mitadrine, which we heard about earlier, to battle with that. Fast forward about a year after that first orthostatic symptom, and then I started getting symptoms of gastrointestinal issues, acid reflux, kind of symptoms like nausea while I was eating, alternating bouts of constipation and diarrhea. So I was seen by a gastroenterologist. They did endoscopy, a colonoscopy, and they couldn't see anything visually that would have tied to amyloidosis. Probably had they taken a tissue sample, they likely would have found amyloid fibrils in the tissue, or possibly impacting the nerves that control my GI system. So that symptom actually caused, over about a 2 to 3 year period, I ended up losing about 60 pounds of weight, which is pretty significant. Shortly thereafter, I had another bout of the orthostatic hypotension. Again, I went to the local hospital here in New Hampshire. Same thing, they brought me into the emergency room. They couldn't see any signs of a heart attack or whatnot. This time they did. They scheduled me and they did an angiogram on me. They got the results back from that, and they saw that my heart looked like it was robust. And they mentioned, especially your left ventricle looks robust. And unfortunately, they attributed to that to I had an athletic background. I grew up playing ice hockey and lifting weights and whatnot. And they actually told me they thought that I had an athlete's heart. Well, unfortunately, what we now know, what they were seeing was an enlargement of my left ventricle due to the amyloid lodging into my heart. So that all took place over about a 6 to 7 year period, and there was we really couldn't get any answers. So now we fast forward to the year of 2018, and I made the decision to accept a job overseas in Abu Dhabi, over in the Mideast. This decision actually helped save my life. I got over there in the middle of summer. I wasn't there a couple of days when I actually felt this uneasiness in my chest again. This time I actually fainted. So I was taken to the local clinic there in the village that I was living in. And they thought, well, maybe something cardiac's going on. Maybe you're just dehydrated from moving here over to the Mideast in the middle of the summer. But they suggested that I go into Abu Dhabi, set up an appointment with a cardiologist. The Cleveland Clinic, the famous Cleveland Clinic here in the United States, has a center over in Abu Dhabi. So I went and saw a cardiologist there. The cardiologist there knew my history, knew that I was experiencing some numbness in my body, knew that I was experiencing these bouts of hypotension. They did an echo on me, saw that my heart was enlarged. That doctor assembled a team of disciplines, endocrinology, cardiology, neurology, and whatnot. And they all saw me over about a 3 to 4 month period. And they were looking for answers, still couldn't find it. The cardiologist conferred with one of his colleagues here at the Cleveland Clinic in the United States. And his colleague suggested it's a long shot, but perhaps it's this rare disease, amyloidosis. So they did a heart scan on me. The heart scan came back positive. It showed uptake of amyloid fibrils in my heart. The doctor over there, he explained to me, he said, it looks like you've got, or a strong suspicion that you've got this disease, amyloidosis. We don't know what type. We also aren't experts in it over here. The doctor knew that I was from Boston, so he set me up with an appointment and advised me to move back to the United States. and see Dr. Rodney Falk at the Brigham and Women's Hospital in Boston. So that's what I did. I moved back to, returned back to Boston in early 2019. Dr. Falk got his hands on me, if you will. He repeated the heart scan. That came back positive. He did blood work, differentiated. He ruled out light chain amyloidosis. So now we knew that it was either probably hereditary or wild type. So they did a DNA sample, sent it out to the Mayo Clinic. The results came back and it said, yes, in fact, I tested positive for the T60A mutation. So Dr. Falk had that information in hand. He sat me down, explained to me the gravity of the situation, that the disease had progressed quite a way, but fortunately they had caught it, and there was a new drug that had just recently come out of trial at that point, drug called patisiran, which is kind of the forerunner of vutrisiran, which I'm on now. So as you heard earlier, patisiran is an RNA silencer. He explained to me that the drug had just come out of trial. I was a little hesitant, so I asked questions. I said, if I'm hesitant to use a new drug, what are my other options? And he told me that, at this point, it's probably the disease had progressed, and if we don't try this, then the result, it could possibly be fatal within a year or two. So that made the decision easy for me. So I started on patisiran in April of 2019, and that was supplemented with also an off-brand drug, diflunisal, to help. They know that can help stabilize amyloid fibrils. So I started that in 2019. That's an infusion that you get every 3 weeks. I did that I got a total of 75 infusions over about a 5-year period, at which time I swapped to vutrisiran, which I'm on now. So I'm pleased to say that I'm now 6 years out from my initial treatment on patisiran, and I can share with you that both my clinical test data, ongoing test data, as well as my quality of life scores show that in my case, there's pretty good evidence that not only has it halted the disease progression or slowed it, it has halted it. So I've actually feel a bit better, a bit more healthy than I did 6 years ago. So that's my story, and hopefully I know that it's a very typical of someone with a mixed phenotype, if you will. I've got the neuropathic and the cardiac symptoms from the disease. Thank you very much for allowing me to speak here, and I look forward to if there's any questions I can answer during the Q&A. Thank you.
Thank you, Sean. Now we would love to answer some questions that have come in. If you've not had a chance to ask a question yet, you're welcome to please put it in the chat. So first question here, when newly diagnosed with ATTR-CM, what should I ask my doctor about my disease? Who wants to take that?
So I'll take that one. So when newly diagnosed, glad that first of all that you that they made that diagnosis, because that means that they suspected it. But if it's ATTR, the first thing is we need to make sure if it's hereditary or if it's wild type. And so usually counseling and genetic testing is the first thing after you get that first test that's positive, that tells you that you have ATTR amyloidosis. After that, I think it's a very important conversation you have to have if you're on the right treatment for heart failure or for AFib, or if there's any other issues that the amyloidosis has caused that might need to be addressed. And ultimately, the most important thing is to discuss the different therapies that are available, which fortunately now we have 3 therapies available, to see which one fits best in your case. Because depending on on your presentation, your doctor might elect to do one versus another medication.
Thank you. Next question is, how is the disease monitored, and how do I know if the treatment is working as it should? Dr. Agumbade, you want to take that one?
Sure. So there are different ways that we kind of monitor the therapy. So depending on what someone receives, for example, if you're getting a stabilizer, that's a medication that helps to bind to the tetrameric form and decreases the breakdown into the monomers, like we've heard about. And so if we measure some places measure the prealbumin in the blood, and so you can expect to see an increase in those levels. And then on the contrary, if you end up with a silencer that actually decreases TTR, we'll see those levels go down. So that's one of the ways we can kind of look and see, okay, what is this medication doing? And is it having at least the intended effect based on labs? We also monitor symptoms, right? So we look to see, is someone developing worsening heart failure symptoms? Are they having more symptoms of congestion? We look at biomarkers, which are tests that we can check in the blood to look at your proBNP, for example. We can say, okay, is your proBNP increasing, or are we seeing a decrease as we're kind of stabilizing the disease? On your echocardiogram, you can also look at the heart function, right? Is the heart squeeze function or the ejection fraction, which is a number a lot of you might be used to hearing. When you get the echo done, they say, okay, what's the ejection fraction? That tells you how well it's pumping blood to the rest of the body. We can look at that to see, is that getting worse over time, or is it stabilizing? And then other things also, you can get a sense, right? Are you having more arrhythmias? Are you having other kind of clinical signs that suggest that the heart function may be decreasing? So those are the things we can look at to assess.
Thank you. Sean, can you answer this one? What physical and emotional impact has this disease had on your daily life?
Sure. Physical, I kind of describe it as in many regards, I had to, and I looked at it as an opportunity to reinvent myself. I had mentioned earlier when I was speaking that I grew up, I was an athletic person. I played ice hockey up until I even played in men's, adult leagues and lifted weights and whatnot. But with the disease, I can't do those type of things. But there are things I can do. I certainly can walk fine, especially on flat surfaces. So what I've done is I've taken up other, physical related hobbies or activities, if you will, that I can do. And one of them is we have 2 dogs that we like to walk. So I take multiple times a day, I'll walk the dogs. I like to discover new trails and rail trails around New Hampshire. So I do that for physical activities. I also was able to identify that I had never really considered this before in life, but I actually have a talent for drawing. So I found that out, and so now I spend a lot of my time as I consider myself to be a fairly accomplished amateur artist, if you will. So it involved lifestyle changes, and I would say that in my own case, I kind of looked at it as an opportunity, like I said, to reinvent myself. So that's important, have a positive outlook and look for things you can do.
Thank you.
Yep.
For the next question, are plastic surgeons who do carpal tunnel surgery made aware of this connection? Dr. Rubio?
Yeah, so not necessarily. That's why we've been trying to raise awareness. Like we try to do it here in our institution, the hand surgeons. We've been trying to teach all the hand surgeons that that this is something that they should be looking at, and that's why we developed a protocol that hopefully once we get enough data, we'll be able to share it with everybody so they understand the importance. And so that way also hand surgeons all understand that it does not take too long. It's a short amount of time. We kind of predict about 5 minutes more to be able to go in there, get a piece of tissue, and then send it. So it's looked at to see if there's amyloid or not. It's the same thing with spinal stenosis in the spine surgeons. That's something that we're also trying to look at to see how we can spread the word so spine surgeons become aware. And in the future, maybe AI will help with that, where some flags will come up when a hand surgeon sees somebody with spinal stenosis, And if they have some of those characteristics, maybe it'll flag. Same thing with other conditions like with heart failure, with AFib, that hopefully will help diagnosis and even early diagnosis, which was our goal.
Right, thank you. Dr. Gubayade, what is the daily dosage of vitamin A that you recommend for your patients taking silencer drugs?
Thank you. So usually 900 units. Good question.
So many of the symptoms of this condition are things that are very common in older people. AFib, spinal stenosis, heart failure, weakness, neuropathy. Therefore, the amyloid is missed and the diagnosis very late. What can be done to make this diagnosis earlier? And any thoughts on broader screening guidelines for patients with HFpEF plus one or more common ATTR comorbidities?
Yeah, that's true, and that's sometimes why the diagnosis is missed, because there's a lot of things happening at the same time. And in terms of patients that are older, usually wild type ATTR, this is missed. And so that's why I think that using our electronic health medical records, different systems, it might be a valuable tool to be able to make this diagnosis where the AI can kind of integrate. But also education, just continued educations by people that are comfortable with amyloid, with different parts of the health system, cardiologists, hospitalists, internal medicine, everybody, so they understand that when they see heart failure, when they see maybe AFib, and then they pair that with some extracardiac manifestations like the bilateral carpal tunnel, rotator cuff tear, bicep tendon rupture, trigger finger, maybe it's too many things that are associated, and then they should look into ATTR. And so hopefully that would make an early diagnosis for those patients.
Yeah. Dr. Agabande, what are the treatments for the advanced peripheral neuropathy?
So for the peripheral neuropathy, we have, so the silencers are currently utilized, and so the neurologists do a really great job of addressing that. So there are mostly the silencers that are being utilized to treat that. And the goal there really is to stabilize the disease, right? Because we don't yet have a cure.
Thank you. Next question is amyloidosis considered as heart failure?
So not everybody that has amyloidosis has cardiac amyloidosis. Some patients that I see in clinic sometimes have had a biopsy that shows that they have amyloid. And then we try to subtype it if it's AL, if it's TTR, and then if it's TTR, if it's wild type or it's hereditary. When it comes to cardiac amyloid, meaning amyloid that affects the heart, or what we call an ATTR, ATTR-CM, or cardiomyopathy, if somebody starts developing symptoms, then they could be in heart failure. But I do have some patients that we've diagnosed very early on that have cardiac involvement and they have not had any symptoms of heart failure. So it's not a synonym, it's not the same thing, amyloid and heart failure. But some patients with cardiac amyloid can develop heart failure. And so that's the goal, is to try to treat early so we avoid progressing towards heart failure.
Yeah. Sean, since starting treatment, have the disease symptoms stabilized or improved?
Yes, I would say that definitely stabilized. And as far as my neuropathic symptoms in my legs and walking and whatnot, that was it was really quite severe when I was first diagnosed. But over about a year or two period from when I started treatment, the neuropathy in my legs improved rather significantly, and then from that point on has remained stable.
Great. And then with a diagnosis of hATTR with polyneuropathy, no signs of cardiac involvement, will the Amtuva address inflammation? Is there apparent systemic inflammation that acts like rheumatoid arthritis? Not sure if cause for inflammation is rheumatoid arthritis or amyloidosis.
So it seems like the question is the patient has rheumatoid arthritis and they've been diagnosed with the polyneuropathy. Okay, and then is that?
Will vutrisiran address the inflammation?
Well, vutrisiran will address any symptoms of the neuropathy that are related to the TTR protein. So the inflammation that may be, if they're saying that they also have rheumatoid arthritis, I think that's something separate. But the vutrisiran will specifically decrease the TTR production, and that's what's depositing, that's worsening the polyneuropathy symptoms.
Okay, very good. So thank you to our speakers, Dr. Agumbade, Dr. Carmona Rubio, and Sean Riley. That was a really informative session. And thank you to our 2025 Patient and Caregiver Webinar Series sponsors, Merck, Abbott, AstraZeneca, Novartis, Novo Nordisk, and to our ATTR webinar sponsor, Pfizer. Remember to visit the sponsors' virtual booth for additional information. And most of all, we'd like to thank patients and caregivers for joining this webinar. This webinar will be available on demand on the HFSA website if you would like to watch it later or share it with someone else. And if you are not yet a member of HFSA, becoming a member is free for patients and caregivers and is a great way to stay informed with helpful heart failure resources. And if you can, please scan this QR code and complete the brief survey to help us get feedback on this webinar. We would really appreciate it. And a link to the survey will also be emailed out following this webinar. Thank you very much.